Welcome back, guys, to another episode of the Health Mastery Show. In today's episode, I have on with me Dr. Karl Nadolsky. Now, Dr. Nadolsky has so many letters and certifications after his name that I can't even get in enough time to mention them all. But at the moment, he is a clinical endocrinologist for Spectrum Health Medical Group in Grand Rapids. He's an assistant clinical professor of medicine for Michigan State University. He holds a board certification on maternal medicine, diabetes endocrinology and metabolism, and obesity medicine, and is currently serving as the chair of American Association of Clinical Endocrinologists Obesity Disease State Network. Karl has also competed at collegiate level NCAA Division 1 wrestling, so that's pretty much the highest level of amateur wrestling you can compete at in America. He's also competed once, I believe, in bodybuilding, and today we talk all about hormones. So can you manipulate your hormones? Is it something that it's worthwhile doing? We talk a little bit about obesity and how that can affect your hormones in a negative way and how losing weight can affect it in a positive way. We also touch a little bit on steroids and how they can negatively impact your overall health. But it was definitely a learning conversation for me, or I took a lot away from this conversation. So hopefully you will too. And if you do enjoy these episodes, please do leave a rating and review on whatever platform you're on, whether that's YouTube, leave a comment, a like, subscribe. If it's on Apple Podcasts or iTunes, please do leave a rating and review. The algorithm does push it up and it helps me get on more and better guests each time. But without further ado, I want to welcome on Dr. Karl Nadolsky.
All right, thanks for having me.
So Karl, or Dr. Karl Nadolsky, what do you prefer to be called?
Oh, that's whatever you feel comfortable.
Okay,
is fine.
No worries. I'll call you Karl. So Karl, can you explain to me a little bit about your day-to-day work, or what you do on a day-to-day basis as a doctor?
Yeah, so I am a clinical endocrinologist and also have a specialty in obesity medicine. So most of my days are working in the clinic with patients referred to us for a variety of hormone dysfunction things, or obesity and obesity complications like diabetes, sleep apnea, metabolic syndrome, lipid problems. But we see a full range of people with actual clinical hormone issues, from hypothalamic pituitary disorders, and that could include, prolactin issues, growth hormone, sex steroid issues, adrenal problems, thyroid problems. We do thyroid cancers. Also bone health, osteoporosis, vitamin D, calcium metabolism. But obviously my big thing is obesity, diabetes, lipids, that cardiometabolic health stuff.
Okay, cool. So the majority of the people that you would be dealing with on a day-to-day basis would be, say, overweight or obese patients.
Yeah, I mean, I guess the majority, but like I said, all those other disorders could be in anybody, from a young adult to the very elderly. They could have, thyroid problems. They could be very, very thin from hyperthyroidism, or even, losing weight dramatically from adrenal insufficiency, so to speak. So, there's a pretty wide range of potential. But yeah, the majority of my patients do struggle with obesity and its complications.
So what do you see with regards to, I know I've read some meta-analysis by, I think it was Naud and colleagues, a 2014 meta-analysis looking at a whole host of different studies or research on, health factors and obesity-related diseases. And it seemed to conclude that losing body fat or losing weight in general will elicit the best response in terms of the reduction of those health problems. Would you tend to agree with that in terms of what you see from your day-to-day work?
Yeah. I think the evidence supports obesity as a disease. We really want to grade the severity of the disease based upon the complications. So, like you said, it's really what's on the inside that counts, right? So I don't personally care as a doctor what people's weight is. I care about what the risk of that excess fat weight is doing to them. So if they have prediabetes or diabetes, we know that 5 to 7% weight loss is really good for diabetes prevention. You start getting over 10% weight loss, we start improving glycemic control and other outcomes, and more than that, and we start getting people, off of their medications with with really good outcomes, maybe even cardiovascular outcomes, although that's been difficult to prove. But the more you respond with the actual weight loss and keep it off, the better. On the other hand, we also have plenty of data to show that even if you do the things that are healthy and theoretically would help you lose weight, even if you don't lose a lot of weight, you're improving your health, so that disease of the obesity can get better, even if you don't actually lose a lot of fat, although the fat loss will help, generally speaking.
So would you subscribe to the idea of health at every size, or do you feel that the weight loss?
Yeah, not exactly, but there's some truth to that, which is why it gets debated. So if head to head, if the same person with the same amount of obesity or adiposity is eating, let's say, a more Mediterranean pattern and is exercising really well with aerobic and resistance training, and they're very fit, they are going to be better off, even if they don't actually lose weight. I mean, they're going to improve their body composition, right? So that's part of how this works. But even if they don't do that to a great extent, they are going to have better outcomes for diabetes, heart disease, et cetera, than they would if they didn't. However, if they lose the weight, the excess fat, they will have even better outcomes. So we know that the metabolically healthy obesity is a probably transient state, especially if it's abdominal obesity, where the adipose, the triglycerides are in the liver, the muscle, the fatty acids are being released, a little bit of fat gets in the pancreas, which is part of the pathophysiology of diabetes. So weight loss is very important, and we've really proven that. But on the spectrum, certainly fitness and healthy eating matters even without weight loss. But we do want to help people lose weight, and so we do focus on that too.
Okay, so it is a little bit reductionist to say that it's only weight loss that will cause the health benefits, and that even a small amount, even if the individual is still obese, by actually losing a percentage of the body weight, 5 to 7 or even beyond, that will actually start to have those health benefits.
Yeah, absolutely, and we have the evidence to show that, and which is also why we try to give people reasonable goals. So I see a patient with type 2 diabetes, and the person weighs 300 pounds. We talk about 10% weight loss being 30 pounds, 15% being 45 pounds. That doesn't sound like a lot. That might not be what that person wants. That person might want to be 185 pounds, but that's not necessarily the clinical goal. Again, to get to the key of it's what's on the inside that counts. So I want them to be healthy and improve their outcomes. I always tell people, I want you to be happy with yourselves too. So I'm going to help you to do everything we can to get you to where you want to be, but you don't have to be on the cover of a magazine to have healthy outcomes.
Yeah, that's quite intriguing. So if somebody was, let's say, morbidly obese, or they're extremely obese, if they lost that, say, 15% of their body weight, and even though they'd still be clinically obese objectively, would they reap all the benefits of someone who's leaner, or would they actually still need to, at a point, would they reach a threshold or a blocking point where they actually need to keep losing more weight because of maybe the negative effects would come back, or the health implications?
Yeah, I mean, potentially, and everyone's going to be different, but it kind of gets back to like what I said. If they're able to maintain more than that, 10, 15 or more % weight loss, and they're doing it with the appropriate fitness and diet, they're going to have great outcomes. And we really do have some studies that show that it almost gets to the point of not having the disease of the obesity, but it's a chronic, progressive, recurrent disease. So it's going to keep fighting. And that gets to one of your other questions, I think, on that whole set point theory thing. But the biology does work against the patient. So they do have to keep fighting it to maintain that and the health benefits. So will that person be the same as somebody who never had obesity, has been fit and has good genetics their whole life? No, probably not. But they're going to reap huge rewards.
Yeah, and we did talk a little bit off air about that, the whole theory of a body fat set point, and it's quite, I suppose, close to me at the moment because I'm dieting for a bodybuilding show, and I suppose I'm reaching my lower end of my body fat set point, and I know that just from how I feel and having gotten tests done before, that that's not necessarily healthy as you get leaner, where you start to have
Right.
reduction in testosterone,
Sure.
reduction in leptin, all of the things, reduction in thyroid hormones. But if you go the opposite direction, is that the same case? Because I don't know if I have a bit of a bias as kind of like a physique orientated mind, where I don't really look at too much into the obesity studies that much, or how it impacts myself, because I've never actually been there. So obviously looking at more of the sports performance research and stuff. But as someone gets, say, heavier or closer to their high end of their body fat set point, and I know it is easier because of the environment that we live in, and the how liberal food is, and the kind of lifestyle that people have nowadays. But is there a point that you feel that maybe even before obesity, that we start to see these reductions in testosterone, reductions in thyroid hormones?
So probably the most common cause of hypogonadism that I see is what I would coin a functional hypogonadism, where there's not a hypothalamic or pituitary injury, or the testicles aren't failing. It's mostly due, there's something called an obesity associated secondary hypogonadism. And it is kind of the opposite of what you were talking about, because there's a functional hypogonadism that happens in, say, lean athletes, natural bodybuilders, where the fat gets so low and the leptin goes low, and it's not affecting the kiss. It's a very complicated thing, but it's kind of a normal response, physiology. Well, in the obesity associated secondary hypogonadism, which is a functional thing, it's again very complex. So you get this altered hypothalamic pituitary axis, causing the testosterone to go down, but it's affected by sleep apnea oftentimes. So sleep apnea is a pretty common cause of this functional hypogonadism, and is a very important thing to discuss. By the way, sleep is huge for just functional testosterone axis. Sleep's a big deal for everyone and everything, but there's also increased cortisol and aromatase, leading to estrogen in the fat cells, which then goes back and negatively affects that whole hypothalamic pituitary testicular axis. The increased inflammation from the adipose tissue, especially the intra-abdominal adipose tissue, and that's what we talk a lot about with type 2 diabetes. But it's all affecting that same axis, and so we know that with those patients, weight loss, especially, a lot of the studies we have are on bariatric surgery, but weight loss can resolve that hypogonadism. But weight loss from caloric restriction, fitness, and probably some medications. On the other hand, if truly hypogonadal, and I'll try to explain that in a minute, but it does seem like possibly testosterone replacement therapy, or perhaps some of the other ways we have for improving that axis, maybe even does help. So there was a study recently published. It's not a randomized trial, but it was a decent trial looking at patients who had obesity and prediabetes and were diagnosed with hypogonadism. And some of them chose to go on testosterone replacement therapy, and some chose not to. Well, the ones who chose to go on it had better outcomes, essentially diabetes prevention, et cetera. Now, some of that's a selection bias, meaning, there are certain people who decided to go on it, they might be more motivated, et cetera. But it's something to think about, and that seems to be somewhat consistent with the evidence. Now, to my point of, did they really have hypogonadism? When you have obesity and insulin resistance, et cetera, you can make your total testosterone look low without your actual free testosterone being low, because it decreases binding proteins. And so a lot of times we get people, I just had a guy yesterday who was referred to me for low testosterone. He definitely, if he has it, he has obesity associated hypogonadism, but he has zero symptoms of hypogonadism, and the symptoms really are critical. And so then when I looked at, somebody did measure a free testosterone, which I don't always trust the measured one, but it was like just into like what I would call a normal range. And so I'm going to, after we work on his weight loss, I'm going to recheck, and I'm going to actually calculate the free testosterone, and I almost guarantee it'll be normal. Because he has no symptoms other than erectile dysfunction, which is more of a blood flow issue, not a hypogonadal issue usually.
Sure, and there's so many topics that you talked on there that we could lead into so many different segues. But
Yeah, sorry. I can go off on tangents.
I think we could talk for hours. But with regard to I think a lot of the research that is done is obviously in obese patients purely for looking at treatments or ways that we can prevent that. But is there a point, and this is something that I've always kind of struggled to understand, is there a point in your level of body fat or increasing body fat where we actually start to see noticeable changes in these negative outcomes? So it's not just black or white where you're either lean or you're obese. Does that slowly start to come on? Because obesity obviously at some point was made at an objective level and say, okay, now you're obese, maybe you don't have diabetes, but this is the body fat percentage for obese. I think, what is it, 25% for men?
But is there? Yeah, I mean, I wouldn't, to be honest, in most clinical cases, we don't we don't use body fat percent because we just can evaluate someone clinically. We use BMI to help us kind of in a population guidance. And those studies are really the most robust, even though BMI doesn't do well for those of us who are really muscular and lean. But that's just more of a clinical decision. But they've done enough studies where we can kind of see where the risk in a population goes up. But it really is an individual thing. So it's hard to answer your question, like at what point for a given individual does it start to go up. But that's why we use BMI a little bit. We use waist circumference, so we know a higher waist circumference, and when we can nitpick that a little bit, and that depends on ethnicity and genetics too. But that's where we really see some of the increased in risk, and it really is kind of an individual thing. So you got to be able to take, let's say, for example, somebody who doesn't have a lot of muscle and they might not weigh much, their BMI might be 25, but maybe they're older and they actually have abdominal obesity by waist circumference. Maybe it's let's say a female with over 80 centimeter waist circumference or a male with over 94 centimeters. But they're kind of skinny, maybe in the fitness world, we'd call it skinny fat sort of thing. And that's actually probably the worst risk of cardiometabolic disease, to be honest.
Sure, yeah, and I've been doing a bit of research into that myself over the last couple of months, and it seems like, and it may not be the only cause, but high levels of glucocorticoids or high levels of cortisol, which would be associated with stress, that it for some reason, and I can't really seem to find a determining factor, that body fat seems to just deposit more so, even though body fat percentage overall might remain the same, you just get more of these body fat adipocytes around the visceral area or around the gut, like you said, which seems to be a little bit more dangerous. Are you able to go into that a little bit, or explain kind of what is going on?
Well, so yeah, basically that abdominal obesity, that visceral fat that is really definitely worse. It's associated with what some call an adiposopathy or a sick fat sort of situation. So our peripheral healthy fat cells, a lot of people don't like those, but they actually are somewhat healthy. The fat that kind of that pear-shaped female phenotype a little bit more, where it's around the butt and the thighs. Those fat cells function appropriately as storage, but when we get more fat around our, in our viscera, in our abdomen, around our organs, and the triglycerides then get in our liver, the fatty acids are released more in our bloodstream. The triglycerides are in our muscle cells, which cause them to not work that well, and then even some gets in our pancreas, and this gets into like type 2 diabetes pathophysiology and and some things that we don't know perfectly, but overall, that whole inflammatory process leads to those healthy fat cells not working, which leads to more inflammation and fatty acid release, and then that's what leads to insulin resistance and ultimately pancreatic failure and type 2 diabetes. So it's pretty complicated, but then it ends up just affecting the whole system. You get the insulin resistance in the liver, the muscle, the adipose tissue that's not working is increasing lipolysis and fatty acids. then the brain is kind of working against you. The kidneys are working against you. The intestine hormones aren't working for you like they're supposed to. We talk about the gut microbiome gets affected, this whole thing. And that's an advanced thought too. Everyone's like, oh, the gut microbiome is important. It's like, well, yeah, it is. We're not exactly sure what to do about it right now, but it definitely is a role. And then so say type 2 diabetes, then ultimately the pancreas fails. So that's sort of a little bit of a nutshell, but it's a pretty complicated thing.
Yeah, it seems like the two areas that people jump to conclusions on when they don't really know what's going on, but they want to have an answer is your hormones and then your gut, and they try to come up with these crazy protocols to try and manipulate the both of them.
Yeah.
So you kind of touched on it there a little bit, but like for example, let's say the skinny fat, I don't know what you would call that clinically, but somebody who is like not
so clinically I would call it sarcopenic obesity.
Okay, sarcopenic obesity. You're not going to tell somebody that they're skinny fat,
right?
But but it is, I suppose, quite common. You'd often see somebody who, let's say, a guy who's actually doesn't look like he has that much weight on him, or in terms of body fat, but maybe he takes his shirt off and he has like quite a large gut. You said it. Obviously, it's a very complicated scenario, and there's a lot of different things going on, but. Is cortisol or is stress related obesity or sarcopenic obesity, a real thing?
So you're asking, is cortisol actually involved? Basically,
yeah. Can higher levels of cortisol in otherwise, let's say, healthy body weight individuals lead to these issues with decreased insulin sensitivity and then ultimately pre-diabetes?
So just for a baseline for people, real hypercortisolism, either from the pituitary stimulating the adrenals, which is called Cushing's disease, or from an adrenal nodule, or very rarely like a cancer somewhere else causing that ACTH to stimulate cortisol, called Cushing's syndrome, is very bad for our body. And the most common cause of it is medical-induced Cushing's syndrome. People get put on glucocorticoids, prednisone, dexamethasone, for whatever reason, inflammatory disease or something. And so it is mostly a catabolic hormone. It's bad for the muscle, basically. So it's breaking down muscle, but it increases the triglyceride in the muscle. It increases the sugar levels, so thus increasing the insulin resistance. It deposits fat more in the viscera. So going to that visceral obesity we talked about, and it's just like everything that's bad and kind of leads to its own version of that sort of skinny fat or sarcopenic obesity. I mean, it's like that hormone does it. So in a normal person without that severe disease, so without medications causing it, without a pituitary tumor, without an adrenal tumor that's causing Cushing's syndrome, there is still this physiologic state of, some people have a little bit more cortisol from stress, obesity. So I think I told you that the fat cells that we have actually have an enzyme that turns the inactive cortisone into cortisol. So you tend to have a little bit higher physiologic cortisol in obesity anyway. So it's another factor that's working against patients. Some other things even cause what we call a pseudo Cushing syndrome, where like alcoholism can cause just a sort of a baseline high cortisol level. And actually, just like I talked about how obesity hypogonadism or low testosterone is probably the most common thing I see, but on the other hand, really thin, almost too lean, or starvation or anorexia can cause low testosterone on the other end. That actually can also cause elevated cortisol levels. So people with anorexia have elevated baseline, daily cortisol production. That's all those things are true and affect it. And so that's why, one of the reasons why people say, okay, with weight and everything, we got to try to help people reduce their stress, get enough sleep. and that sort of thing. But we're not going to give any medicine to people without a true pathology to try to lower their cortisol levels. We just try to do it with lifestyle.
Yeah, and I know that you spent a couple of years as a pretty high NCAA wrestler, and you probably got a couple of injuries back then. And so would then you disagree with the usage of cortisone injections for injuries? Do you think that that's actually harmful in terms of potentially leading to muscle wastage or even
Sure.
diabetes?
Yeah, I mean, amazingly, so in my career, my real career, I actually never. I think maybe I got a glucocorticoid injection when I was a senior because of I was on vacation and I had like one of those sun-induced allergic rashes. Have you ever heard of that? So I remember that it was
Like
horrible.
sunstroke.
Yeah, well, yeah, not well, anyways, it was a rash and it was an allergic thing. I got a steroid injection. That was crazy. I never got one for an injury in my real career. Interestingly, probably because of my career and some genetics, I now have a really bad arthritic left hip with a with a torn labrum, and so they did inject it with steroids a couple months ago, and I was really, as an endocrinologist, I was really hesitant to do that because I know the adverse effects of those, but I tried it to see if it would help, which it didn't. But anyways, we do have patients who get sort of that Cushing syndrome, again, medically induced from steroid injections. Absolutely. So that counts. Sure thing. And inhaled steroids that people use for asthma, it can add up. It can definitely accumulate and cause those adverse effects. Now, that doesn't mean you shouldn't do those. So please, anybody listening, don't stop the steroids that your doctor told you to take. I'm just saying it can happen. And some medications combinations can cause a decreased metabolism of them. So, there's like a classic board question for us where, it's somebody who's been on, some inhaled steroid and maybe they have HIV and they're taking a certain medication that decreases it and they have what appears to be like Cushing syndrome clinically. But then what they actually also have is they have adrenal insufficiency because they've been taking essentially high dose steroids, or at least it's been metabolized or not metabolized so that they suppress their own adrenal axis. So not only do they have medically induced or iatrogenic Cushing's, but now they have adrenal insufficiency too.
Yeah, so I guess everything is
that's a whole nother thing.
Yeah, everything is a bit of a trade-off. You kind of pick your problems. You either have a severe asthma or you potentially have higher cortisol levels.
Yeah, and so you just got to do the best you can. We talk about steroid sparing therapy. We always want people to use the least amount necessary to get the benefits over the risks. That's all.
Yeah, and although these are a different type of steroids, I wanted to talk a little bit about what your thoughts are, or what are the negative impacts, or are the negative impacts overstated of actual exogenous steroids for muscle building? Because I know it's in the US, it's illegal. In Ireland here and in Europe, it's not actually necessarily there. It's a big gray area, but the use of it is pretty high, especially with I suppose the rise of social media and bodybuilding and all these great bodies. People kind of turn to steroids for the quick fix, or they think that it's going to help them build muscle. Well, will help them build muscle faster, but they don't necessarily always understand the negative impacts. You get these people telling you about it, but often they don't have a really informed view of what you might have based off of your experience, but also your insight as somebody who is a lifter, a weightlifter, somebody who's wrestled, and you have a pretty good physique. So, what are your thoughts on that? Because I'm sure you've come across it in your work and also outside of work.
Yeah. In fact, I just had a patient the other day who came to me for fertility because he has hypogonadism because he used some anabolic steroids for like only 16 weeks when he was 17 years old. So yeah, and people might know my younger brother Spencer, who's also a family practice doc and has a big social media following. We've been working out since we were little kids, eating well, wrestled in college, played football, all that stuff, and so we're kind of used to being around other somewhat elite athletes with physiques that are maybe above average, but we've always been very, healthy and kind of anti-drug, and we don't like taking medicines that we don't need to. And so we've always been anti-anabolic steroid and have always recommended it. Our dad was a science teacher, both of our parents were teachers, so we were very into, the healthy living of sports and athletics. And to be honest, my personal opinion, no offense to anybody, but when it's done for sports, it's cheating, in my opinion. But yeah, you're right. People do it, and we've been falsely accused of taking steroids our whole lives, despite the very stable, physiques we have and healthy internal, health and really no evidence of ever doing it. But that's a whole nother can of worms. So part of the reason we never would do it is, one, I'm not exactly sure why. Unless it's like a professional bodybuilder where for whatever reason that's like part of their sport to be at that level, why people would, feel like it's worth taking medicine that you don't really know the adverse effects, and there are adverse effects, just to increase muscle growth. We want muscle. Muscle is healthy if you do it in a healthy way. But there's an article that I just pulled up, a review article on, helping young men with anabolic steroid-induced hypogonadism and fertility, and it actually has a little table of what kind of the usual steroid, anabolic steroid regimens can be, and it just blows my mind how much people are taking according to this. So, a kind of a usual, like for someone who actually has hypogonadism and we give testosterone replacement therapy, a very average amount of something called testosterone cypionate, which is an injection. Preferably, I don't even like the injections because they're not stable and they're not very physiologic, but it's about 100 milligrams a week. Well, this is talking about, and you might even know some of what people do, but this is talking about starting with 500 a week, going to 750 a week, and then 1,000 a week for several weeks. That's a ton. And then they talk about adding the decadurabolin anabolic with some dianabol, and then all this crazy stuff. And it's just like it blows my mind that they would do that when the risks of that high amount of testosterone just so far outweigh what I could ever imagine the benefits. So one thing I'd be really worried about with that is, so just even testosterone replacement in general, we worry about something called polycythemia, which is essentially just increased blood cell production. It's actually why testosterone replacement therapy is good for those with hypogonadism who have anemia, because it actually helps improve their blood cell. But when you have too much of that can increase risks, cardiocirculatory risks, maybe blood clots. There's some concern of that, strokes, etc. You can kind of think of it as making your blood thicker. That doesn't sound very good to me. But then, it's also not good for our lipid metabolism. So it tends to cause a more harmful sort of cholesterol aspect, which increases our cardiovascular risk probably. It's, there can be some like direct cardiotoxicity or harms to the heart, it seems like. I've definitely seen in my practice, especially when I was a resident, I remember there was a guy, and he was admitted, he was a Marine. I was in the military, and he was using steroids, and he had heart failure, and there was no reason that he should have had heart failure, and he was in his 20s. And so that's a concern. Obviously, just other aspects like, they get acne, probably hair growth where they don't want it, testicular shrinkage, potential infertility, like I was talking about. Like I have a patient the other day who came in for that. Some of this can be reversed, when you stop it, and we can do some other things to help patients recover. But it's really just there. I have always been adamant that I would tell people, athletes, young kids, natural bodybuilders, just do what's good for your body. Fitness should be healthy. So why would we start taking drugs especially at levels that are unhealthy, just to have bigger muscles. I mean, I know people are always going to try to cheat in sports kind of thing, and so we got to keep an eye on that. But I really don't think people should risk their health just for whatever benefits they think they're going to get. That's my soapbox on that.
Yeah, and to mirror to the what you said there, I did some research myself not so long ago, and looking at I think the range that they studied for HRT was something like you said 100 to 125 milligrams, and it didn't seem to have too severe negative consequences in the short term at least. But like you said, people are, when they do steroid cycle for like bodybuilding or for just for aesthetics, quote unquote, they're taking not just testosterone or 5 times the dose, but also these other things that are not even made for humans, and just we don't have any research on it at all. And I think some of the research showed that there was an increase in the left ventricle within the heart, the growth of that, because the heart itself is a muscle. And some of the bodybuilders that have died, their heart had been something like 50 to 100% larger than what the average heart should weigh. I think on an objective level, it is it is obviously not ideal or not a good idea to take them. But I think, speaking as a young man, I think it's more emotional guys that they often feel pressured, or they feel like with the rise of, I suppose, social media and bodies, that they think that it's probably going to bring them a better life, not in terms of just physically having bigger biceps, but more confidence, or getting better women, or whatever it means. And so I guess.
Yeah, and I mean it's ironic. I mean, because then you also have the whole dad bod thing, and I'm like, oh man, I guess do I have to have a dad bod to be more popular? I don't know. It's the opposite.
Yeah, I guess it's just a bit, based off of your biases and what you believe to be true, or your circle of influence. But beyond that, I suppose, with regard to then, I suppose, hormones for, say, building muscle or optimal body composition within the physiological range, so what we can do naturally. You talked a little bit about some of the lifestyle factors that we can manipulate or take control of ourselves. And what are those things that, and I suppose you probably bring this into your practice as a doctor on a daily basis, because you talked about trying to get people off their meds and trying to get them to improve habits. What are the main things that you would look at doing, and do you have any specific recommendations around quantities of sleep or certain even certain types of foods that you would advise for people?
Yeah, certainly. So I think one of the first things you mentioned was does the level within kind of the normal range matter that much? And so this is a really hard question, because some of the studies we have would maybe suggest that. I mean, I think, recently there's been a lot of debate about the female track stars who have higher levels of testosterone because they have some, this gets into other endocrine issues, but they have, some genetic causes of higher testosterone levels, and there tends to be a correlation with some performance, and there's some of that in males, but it's real hard to delineate that, because really for overall within kind of the normal range that's been studied, there's really just individual variability. Each guy, at a healthy level, as long as everything's intact, seems to just be different, in all honesty. So, as far as nitpicking, worrying about your levels, I don't, first of all, people should not check their testosterone, in my opinion, unless they're doing it for an academic purpose, or if they really have symptoms of low libido, they're, along with, lethargy and, maybe erectile dysfunction, but they're losing muscle, they have testicular changes, all that kind of stuff. To be honest, I would just not worry about it, and I would do the things that we're about to talk about for just keeping your body optimal. And and I do think sleep is really the unsung hero. So first of all, if you have obesity or potentially other issues with your neck, even neck size, unfortunately for those of us with big muscular necks, and tonsils and all this stuff, if you snore, if there's a chance you have sleep apnea, if you wake up not refreshed, you feel like you're falling asleep during the day, then you need to get checked for sleep apnea. And that's a big deal and causes, true, hypogonadism. And even just poor sleep, not getting enough sleep. So we have patients that just don't get enough sleep because they got stuff going on. They're busy. They got kids. They're staying up too late watching TV. Then they get up early because they have to work. That tends to not be good for all sorts of our hormones, including guys' testosterone levels. And that can, actually cause some real problems in addition to just feeling like garbage. And then sleep hygiene factors. So, having that goal of 7 to 9 hours of sleep, but that can be pretty individualized. We have studies that say, 7.5 is right, more than 8 is right, more than 9 is bad, that kind of thing. But, somewhere in there is appropriate. And probably an individual can kind of figure that out where he or she feels best. But then how do you get to that point? Well, having a somewhat regular bedtime, is appropriate. Not looking at all the blue light screens that we have. We have our computers and our tablets and our phones and the TV, and that's, that gets into some areas that aren't necessarily my expertise. But I always tell patients, it's messing with your rods and cones, and it's causing your circadian rhythm to be all screwed up, and you're not sleeping well. That's kind of the basics of that. And then people drink caffeine too late in the day, and then they don't sleep well. Having a dark room is appropriate. Some what they call ambient noise with a fan is good. So I personally try to do all that stuff. I probably do watch TV up until my bedtime a little bit, but I don't have it in my room. We go to the room and go to bed. The lights are off, the fan's on. I don't stay up late even on the weekends, generally speaking. Generally have a normal bedtime, and I try to get over 7 hours of sleep for sure. I'm pretty anal about my sleep because I do think it's how important it is.
And
so, yeah.
Do you have any specific recommendations for food intake, even within, let's say, an isocaloric diet where calories are the same? Mm-hmm. And do you think that certain foods can manipulate your hormones for the better, like certain types of fats we often hear, but we don't really know with the research if there's too low a fat intake, if there's a certain saturated fat intake, and some people even go way too far with that, and we can have some LDL issues when that gets too high. But it's been quite popular with the butter coffee and stuff.
Oh my God! If you Google our last name Nadolsky and bulletproof coffee, you'll see our opinions on that stuff. But I think there is, although it's hard to say. So I think one thing you noted was the isocaloric sort of thing, because anytime we're too restrictive, it's going to be a problem. So as a natural bodybuilder and me as a wrestler and stuff, we know that a really restrictive diet in any which way and becoming very lean is going to cause, everything to kind of shut down physiologically. The testosterone is going to go low. We even get what we would call sort of a sick euthyroid sort of thing going on, which is not, again, pathology, but it's sort of a normal response. The thyroid levels just all kind of go down. But that's okay. To some degree. People think it's a problem, and that gets into the whole, some of that set point theory, and people call it metabolic damage, but it's actually just normal physiology, to be honest. So an isocaloric diet, not being too restrictive, is important no matter what. And I do think that overall quality, I think if we dug through all the studies and all that stuff, it seems to support, say, appropriate testosterone health. So, more vegetables, good, appropriate, lean protein sources, and even vegans, if they do it right, they obviously still have healthy testosterone levels, because I'm sure you've seen vegan bodybuilders, they do okay. It might take some more effort, I think, but they're doing okay. But they're eating really good diets overall. They're probably getting certainly a good amount of fat from nuts and seeds and and olives and that Mediterranean sort of pattern. That's what I really push for cardiometabolic health. I think it has the best overall evidence for heart, diabetes health, regardless of the otherwise macronutrient content. I do think highly processed, refined carbohydrates are probably not good. In general. On the other hand, I think if you go too low carb, it's probably too restrictive and seems to, maybe correlate with some of those, abnormalities also. I think, there's something to say about some saturated fat and dietary cholesterol being part of the process of some of the steroid pathways that we have for making some of these hormones. On the other hand, very low levels of cholesterol in our blood, our lipoproteins that carry cholesterol, generally don't cause problems because most of our cells are able to make cholesterol or and make those hormones without the LDL passing it on. But LDL does transport. I mean, LDL and HDL do transport the cholesterol to be used and create some of these hormones. So so I would say a big thing is to not be too extreme. So I wouldn't be extraordinarily restrictive with carbs necessarily, but I often prescribe trying to get your carbs from vegetables, fruit, legumes, and not necessarily processed starchy carbs. But that's also part of my my patient population. A lot of them have the metabolic syndrome diabetes, so we're really trying to cut down on some of the carbohydrate load that they're getting and help them lose weight and be good for their insulin resistance and their lipids and health. So an athlete probably is going to have a higher carb, maybe a lower fat diet. So bodybuilders often do better with that. You might be able to speak to that with personal experience and with your coaching experience. I think generally, athletes and bodybuilders will cut down on the fat more due to maybe the muscle sparing effects of carbohydrate and the energy and all that stuff. What do you think on that? Just your opinion. Is that kind of right from a coaching standpoint?
I think from a performance aspect and I suppose in a kind of bodybuilding term, not being too flat where you're just completely glycogen depleted. And you'll know as a wrestler, you need that have that glycogen to be able to perform better, and just getting overall training volume in. I think that not going too low on fats where you're so deficient where you don't even have enough fats for your essential fatty acids, but at the end of the day, I think it's just really down to personal preference, and you'll probably agree with me on that one. Once there's a balanced diet and the adherence is the most important thing, getting somebody to maintain some form of calorie deficit, especially.
Yeah. I mean, this gets back to our talk on obesity and dietary therapy, and it's all pretty much every fad diet you see can work, and we can use these as tools for patients, but I always individualize. And like I said, I push more of a little Mediterranean spin to it, but it has to be personalized. Absolutely. If they want to do keto, great. I'll try to get them to be a little bit more Mediterranean keto if they want. If they want to do some intermittent fasting, that's great. I can't do it because I get hangry. But it's a tool. If you would have asked me 5 years ago, I would have said, that doesn't sound right. But it's been studied and it works especially for obesity. Low fat, low carb, all these different things, paleo, whatever. We can personalize all these different things to try to be reasonable, though. That's the key. Not drinking butter. That's not reasonable in my opinion. Stuff like that.
Yeah, I actually recently interviewed a guy who counted his calories, so he made sure he's in a calorie deficit, but all he ate for 100 days was ice cream and whey protein, and he lost 30 pounds.
Sure.
He improved his his blood markers, his cholesterol levels, and he obviously felt like crap. He said he had no motivation, no energy, but
really?
It can be done.
Yeah, probably not the best way to do it, although one could argue that whey protein and ice cream probably not the worst things in the world, to be honest, to be eating. I mean, but there's the guy who did the Twinkie diet. That's probably the worst thing to eat and lose weight. That's not a healthy way to do it, but he probably got some benefits just from the weight loss, but probably not the type of benefits I would want my patients to get.
Yeah, in terms of the overall lifestyle habits. Right. But Carl, I want to come back a little bit to what we touched on briefly on manipulating hormones within the physiological range, because I have some clients, and I know young guys who come to me that they're very heavily invested in their health, and they want to always improve, and they want to build as much lean natural muscle as possible, and they might have get a testosterone check done. It's actually quite popular in the last 2-3 years. We get these home testing kits. I don't know what your opinions are on those.
I wouldn't spend your money on those. I mean, I wouldn't trust them. I don't know that they're validated. If they're home tests, that probably means they're using saliva. And I don't. Is that the case? Do you know if the people are
You
doing
can
saliva or they're
actually,
doing blood?
yeah, you can send them off to a lab. So there's a few different companies now where they'll get a little vial of blood, where a finger prick or so on, and you'll send it. And I assume that it's assessed in a university hospital somewhere or something like that. And you can get like they have like a men's sports performance, or your thyroid panel, or different hormone kind of bundles that you can get. But I mean the real reason that I'm asking this is, let's say that a young man, let's say in his 20s, he will get his testosterone, or free testosterone or overall testosterone, and he feels normal. And I think you kind of briefly touched on this, but he feels normal, but he feels like it's a little bit low, even though it's in the natural range. Maybe it's 300 nanograms per deciliter, and he's looking at these other guys saying, well, I'm trying to get it to 1,000 because I think that I'll build more muscle then. Is there any truth to that? Because even personally, I actually got my testosterone tested when I started my contest prep, because I want to get it done at the end to see the drop. And it was actually, I was feeling fine, a lot of energy, strong, but it was low. It was actually quite low, but in the normal range. So I wasn't worried about it, and because I know that there's acute effects. I could have had bad sleep or whatever.
Exactly.
But
what was it, by the way? Do you remember exactly?
I think it was something like 250 nanograms per deciliter. So it was quite near the low end. I felt normal. My libido was normal. Strength, I've even been accused of being on steroids, and my testosterone is really low. So I guess there's more going on than just what people think is testosterone. Testosterone is something like from the 90s or the 80s, where we think that that's all that matters. But I think there's a lot more coming out to show that maybe that's not all that's going on with building muscle.
Absolutely. You just hit the nail on the head. I mean, it's so much more complicated. And by the way, testosterone is a very individualized thing when it's healthy. That normal range, 300 could be normal for us, which every time, again, I've done it for academic purposes in residency and fellowship. And maybe part of it's because we generally eat well, we stay pretty lean, and sometimes we're in a caloric deficit or whatever, but it's always kind of been on the lower end of normal too. And I thought, well, that's interesting, but zero symptoms, so we have no evidence of clinical hypogonadism, no low libido, morning erections are normal, shaving's normal, muscle mass obviously normal to the point where people think we're taking extra testosterone. So it really does go to show that we treat people, not numbers. And so you might have, and first of all, by the way, you have to check your testosterone at essentially like 8 a.m. while you're fasting. Otherwise, it means nothing. And so that's another thing for people who are doing these home tests. Again, I never would recommend people just getting labs on themselves, because it always causes more problems than good, especially if they don't have symptoms. But it has to be done first thing in the morning after a good night's sleep, fasting, to even get an idea of it. And then it can vary for any individual. There's a lot of inter-individual variability, intra-individual variability, and number doesn't define you. And 800 in the morning could be normal for one guy, 300 could be normal for another guy, and then they fluctuate anyways. So that's the idea when we look for pathologic hypogonadism, is we get it once and then we confirm it. We decide, first of all, does the person have clinical evidence of hypogonadism? Is the testosterone low? And then we look at all the other factors. We get the pituitary hormones to see, well, is it a pituitary problem, a testicular problem, and then anything else that might be affecting it. All the other, some of the other hormones, iron studies, etc., often get MRIs of the pituitary. So for the guys that just want to manipulate their hormones, lifestyle's medicine, appropriate exercise is medicine. If it's really low, you would have symptoms of, you might be losing muscle, have the low libido, low sex drive. A 25-year-old guy should not lose his desire for sexual activity. You know what I mean? When that happens, that means there's something wrong. Does that make sense?
So outside of you actually actively knowing it, and when I was 21, I think I did my first competition, and for whatever reason, I dieted just really, really hard for a long time and lost a lot of fat, and I just remember that Christmas, I just didn't enjoy. That was the first Christmas where I didn't enjoy myself, and I was like, something's going on here. And I actually got my testosterone checked, and it was like outside of the normal range, like really low.
Yeah,
and I didn't know why, because I'm actually leaner now. I guess it was just the aggressiveness of the diet.
Probably.
But I mean, probably outside of that, like I hadn't got my testosterone checked up until this year, and like you said, more for just curiosity, academic kind of, not non kind of study based academic research, my own personal kind of intrigue. But so I guess then, if we can't really change or manipulate, or I mean, it doesn't really make that much difference once we're feeling normal. Do you think that most supplements for testosterone boosting or trying to manipulate your hormones are kind of futile, or not really useless, like taking zinc or taking ZMA or D-aspartic acid or any of these testosterone boosters?
There are, so those things you just mentioned, along with like fenugreek, there are some studies that show that they might work a little bit. The amount, though, the absolute amount, I'm not sure has any clinical relevance necessarily. Like, is it really going to help anybody if they're otherwise healthy and in the normal range, and it's just we're showing some biochemical evidence that those might increase it? On the other hand, some of those things aren't harmful. So, when we talk about supplements, we have to decide, first of all, is there any benefit? If there is benefit, that means it's a medicine, by the way. If we're actually doing something medicinal that's changing our biochemistry, that means it's medicine. So don't just think every supplement is safe. So that also means you have to be aware of the side effects. So then, are the benefits outweighing any risk? And most of those things you just mentioned, probably the biggest risks are the money you spend on them, to be honest. And because there are some other benefits. I mean, like the fenugreek, I think there's some lipid benefits, maybe even some glycemic benefits. They're all probably marginal, to be honest. I don't take anything. I take fish oil, and I take vitamin D in the winter, and that's what I take. I've taken creatine before. I don't think I've ever tried any of those things. I think maybe my brothers tried them. I mean, we're open to experimenting with some, what seem to be reasonably safe things like that. But I'm also, to some degree, a little bit, I'll call myself frugal. So I don't want to spend money on stuff that I know I don't need it. Like, it's not going to do much for me, I don't think. I don't know. I mean, but I'd be willing to try any of those things you just mentioned, because I think they're all reasonably safe. Maybe I tried the ZMA once because I've had some sleep issues in the past. I think maybe I did try that once. But
I think as a lifter, it's like your rite of passage to spend hundreds, if not thousands, of dollars on supplements before you realize that I'm burning a hole in my wallet here.
I was always kind of lucky to get. For some reason, I always got stuff. Like, people give me like their old creatine and stuff, so it's like seemed like I never really spent that much money on supplements because of that.
Yeah, I think probably because you're already pretty large and muscular, people just gave you stuff. I think I was watching a documentary on Netflix recently where there was an NFL player said that he got rich, and when he got rich, people actually start giving him more stuff. It's like the Matthew's law, the rich get richer, the poor get poor.
Oh my gosh.
But I think we're pretty much coming up on time, and I just have a final question for you. So what kind of, if you had, say, 3 or 4 tips to with all your experience in endocrinology and working with people hands-on on a daily basis, what 3 or 4 tips would you give to somebody that is looking to maximize or optimize their hormones so that they can build muscle, feel better, look better, and just have an overall better quality of life?
So I think, the real key concepts are personalizing your habitual lifestyle plan. I would really emphasize sleep hygiene. Sleep is the unsung hero. It's very important. Obviously, anyone listening to this knows you have to get in your workouts, but I'd also be careful about overtraining. So, making sure you're doing your giving your muscles appropriate rest periods, that periodization that we talk about, but going hard when you get the time. With your workouts, I prefer people to do a little bit higher volume, maybe not overtraining, but higher volume, not so much, the 3 reps and 4-minute rest periods, but lower rest periods, higher volume for overall metabolic health, but also not, overtraining to the point of feeling exhausted, because then that's going to work against you, right? And then the same with nutrition. I would avoid extremes, I would, for most of the people listening to this, for the most part, I would focus on the quality over the quantity at first. Eating lots of vegetables, legumes, fruit. If you're going to eat, starchy carbs, getting it from, appropriate sources like, say, potatoes, sweet potatoes, oatmeal, that sort of thing. But then getting, your lean proteins in from fish, chicken, lean beef, preferably, not necessarily the fatty meats, where we can get some adverse effects. And don't drink sugary beverages. On the other hand, don't drink fatty beverages like bulletproof coffee. I would advise against that. But get your fat from nuts and seeds and olives and fish, and for most people, probably not being too restrictive on, reasonable sources of different types of saturated fats like cheeses. We have evidence that dairy is probably healthy, and then you're getting some of those short chain saturated fatty acids that maybe have different health benefits, but it's from a source of food that, probably has more health benefits than harm. But maybe a little bit of fatty meat once in a while. Probably we would advise avoiding processed meats. Those are probably the ones that we know are probably not healthy, and not being too restrictive for some treats once in a while. A treat is a treat. If you do it every day, it's not really a treat. It's just kind of part of a crappy diet. But if you have a little dark chocolate every day, with your nuts, or even some regular chocolate once in a while, or some ice cream once in a while, that's probably all reasonable. And then if you do need to lose weight, obviously we've got to look for areas of cutting out some of the energy. But I think quality diet is important for most of the people that are listening to you. And then, getting in hard workouts, but appropriate periodization, rest, not overtraining, and really emphasizing the sleep.
Thanks so much for that. So basically what you're saying is that I can go and have cheeseburgers for dinner tonight.
Yeah, especially if you make your own. When we do burgers, I like to have, a little bit of these low carb, thin buns. And, I used to do really lean burgers. But you know what? Now we don't do it as often. We're like, if we're going to have a burger, we're just going to get regular beef and we're going to enjoy the burger. But our steaks are usually pretty lean, I'll tell you. But if you're gonna do it hard, right?
But,
to some degree, you gotta enjoy life too.
Yeah. Thanks so much, Dr. Carl Nadolsky, for coming on today. So, where can people go and find more about you?
So, I do have a Facebook page. It's just Dr. Carl Nadolsky. It's my Facebook page, and that's essentially the same as my Twitter and Instagram handle. It's just at Dr. Carl Nadolsky. And then we do have a website, www.docswholift.com. It's not the most updated site all the time, but it has some of the stuff we've talked about in the past. And if anybody needs any endocrine help, I practice mostly in Holland, Michigan, based out of Grand Rapids, Michigan. So.
Well, thanks so much, Carl. I'll put all those in the show notes, and again, appreciate you coming on to talk to us today.
Sure thing. Thanks for having me.
So I hope you enjoyed that episode with Dr. Carl Nadolsky. As I said in the beginning, I did learn a lot from this episode, and I found it very intriguing. I really like to learn about this kind of stuff and hormones and everything like that. Most of the time, it's probably not worth stressing over if you just get your body in shape or getting the good health. But one thing I do like to, or one reason why I do like talking to people like Carl is that he's got an insight into like the area of bodybuilding and competitive sports. Whereas you've talked to endocrinologists or just general doctors, like general practitioners, they often will tell you to do things that go against your goals. So that in natural bodybuilding, it's quite evident that if you get really, really lean, you're going to mess up your hormones or suppress your hormones, but it will only be acute, or at least for a couple of months, and they'll come back to normal. Whereas if you went to a normal doctor, they just tell you never to compete again. And obviously that's never going to happen. So it's great to get on guests like Carl. And if you did, or you do want to learn more about Carl and his work, I'll leave all of his social media profiles, his website, etc. in the show notes or the description, and you can find out more there. And if you have any questions regarding this podcast, please do feel free to just leave a comment or reach out to me. You can get me on my email, or you can get me on my DMs on Instagram. But other than that, please do comment, subscribe, and leave a rating and review. That would be very much appreciated. But other than that, I will chat to you in the next episode, and we'll have on more great guests.